Nah, so kalau saya tak suruh kamu tengok lurus, kamu tengok bawah tengok. Kalau kamu lebih selesa lah. Bagus ni. Masih masuk. Mau meja tinggi sikit lah. Rendah sikit. Tinggi sikit. Tengok bawah tu. Tengok bawah tu.
Okay. All good. All setting is good. Your screen can be seen. You have started the recording. So go ahead and assess your fitting. Later we look at it together. Huh?
Yeah, sure. No problem.
Is your patient okay? No watering. Everything is okay already?
Yeah, no watery now. Better, huh? Yeah, better.
Comfort.
Just now was watery.
Okay. Yeah. So if let's say there's watering, just let us give her a little bit more time, maybe if needed.
Okay, okay.
But go ahead and proceed with your fitting assessment. I'll come back and then we can have a look at it together.
Okay, sure.
Okay.
Okay, look straight. Okay, look to here. Look over here. Look over here. Look over here. See? Okay, look over here. Okay, look up. Okay, look down. Okay, look, gaze down. Just gaze down, huh? Okay, look straight. Okay, gaze down. Look straight. Look straight. Okay, gaze down. Okay, look straight. Okay, try to blink your eyes. Blink again. Okay, blink again. Blink. Okay, gaze down. Just gaze down, huh? Oh, left eye. Tengok. Okay, look straight. Blink your eye. Okay, blink your eyes. Okay, Note namanya. Note downward sikit. Okay, note upward sikit. Okay, note bawah. Note up. Okay, look down. Yeah, gaze down. Okay, try to blink your eyes. Look straight and blink your eyes. Okay, blink your eyes. Okay, blink your eyes. Blink your eyes again. Okay, look this side. Look this side. Look this side. Okay, look gaze down. Relax a bit. Kenapa tuh?为什么还有镜子？ sudah lepas 30 kan? So, merah, merah, merah. Berapa agak? Merah, merah, merah. Mungkin tak ada sebenarnya. Discontinue lah this. Pakai Bitcoin kan? Kau mau cek apa? Cek harga kah? Cek apa? Test paper. Tak ada, tak ada. Pakai yang kita punya lah. Kita punya itu macam lama tak jual sudah. Tag tu. Dulu banyak ah. Di sini saya ada. Oh, 你跟他讲咯，没有咯，就 refund refund 掉了。因为你要 check 一下有没有啊，还有没有做，所以你不可以直接给他价钱，你懂一下。
Okay, are you doing your over refraction, Jerry?
Yeah, I haven't put the fluorescein on. Need to put the fluorescein?
Yeah. Let's check the fitting. Did you have a look at it yourself already?
Yeah.
Not yet.
I already put in the text photos, so probably just directly see the photo lah.
But you haven't put fluorescein, isn't it?
No, I haven't.
Let's
So
put the fluorescein, then we look at it together, like easier that way.
can.
So just based on your observation with the white light, what do you think about the fitting? Is it okay? Is it not okay? What do you?
This because this time I fit the most accurate one. So
Okay,
so it's better. I think it's better. Better
is better.
fitting.
The
Yeah,
movement and all that, is it
yeah.
acceptable to you?
Left side not sure because next left side I think the nestle there got some pterygium, so maybe it's making it moving towards the temporal.
Okay, we'll have a look. Yeah,
Uh,
okay. So
you
let's have a look. Yeah.
now? You mean now?
Yeah, we can do now. Yes.
Yeah. Chin. So just look at the left lah.
Both eyes, put the fluorescein both eyes so we
Oh,
can
both
assess
for same.
together lah. So we can quickly assess both eyes together, so easier. Then you
Chin.
can do your over refraction.
Okay. Look up. Look up. Okay, look up. Yeah. Okay, look straight. Okay, clean your eyes. Clean your eyes.
Okay, so in terms of centration, I think the lens is slightly decenter inferiorly, but the
Yeah,
optical
inferior.
coverage is okay, right?
You mean the horizontal? Horizontal is quite okay, right?
Horizontal is okay, yeah. Vertically only, I think inferior a bit.
Yeah, usually inferior. I'm not sure why.
Mm,
Because the eyelid on the top.
yeah, maybe because of the pressure of the eyelid. But if you remove the eyelids, I mean, not
Open your
remove,
eyes.
like if you open the eyes, what do you see? Is the lens quite okay? Center, right? Yeah, is the eyelid actually pressing the lens
Yeah.
down? That's
Yes, yes,
okay.
yes.
Sometimes it's okay lah.
Okay, so this one, how's the fitting? Central seems pulling also.
Slight,
Central.
yeah. So when you assess fluorescein, I will advise you want to remove the leads. You want to not remove the leads.
Oh,
Sorry, I keep
oh.
saying remove the leads. You want to lift the leads and
Open your
yeah,
eyes. Yeah, open your eyes.
then open the yeah. So yeah, it's slightly pooling in the center, but just nice. I think it's not too much of a pooling. So I will say
Something
it's
like this.
quite okay. I think. Maybe one step should be okay.
Mhm.
And then the mid periphery also have a good amount of fluorescein, and also the edge is quite nice. Even though it's not 100% same on all side, but it is quite acceptable, I think.
The fitting should be central. Eh,
I will say
central,
central pooling to alignment.
and then if not mistaken, the middle should be black, and then the side should be with
Uh,
some
we no
the
For RGP, we want a diffuse kind of fluorescent. I think it's good enough. It should
the whole
have
thing.
fluorescent. Yeah, yeah. So
Oh, do you
looks
have a picture?
okay. Looks
Looks
okay
okay.
to me.
Need to look left, right, or what? Anything? It's
Yeah,
okay already, right?
yeah, okay, yeah.
Okay,
Because I think the
look
lens
up.
is quite stable. It doesn't cross the
Yeah,
limbus. Yeah.
look there. Yeah, this one also got pterygium. Look here.
Yeah, this one also got pterygium, so it's blocking the lens to go. But the lens
Look,
is quite
look
okay.
down.
This one is your patient or your staff?
Stop, stop.
So you must advise her, pterygium must wear sunglasses.
So left eye,
Okay, let's look at the left eye.
look straight. Like no, where's the lens?
Maybe decenter already. Look up, find the lens down there. So
Look here.
gently ask the patient to look away from the lens and then
Yeah. Look here. Then
mm,
look middle here. Hey,
slowly. Yeah,
look in the middle. Look in the middle.
yeah. So it's watering now.
Maybe another tissue.
Let so it looks like the left lens is
Very loose.
loose. What base curve again? Left is 7.8, isn't it?
Actually, both eyes is seven
No, I mean
seven
the
point seven.
lens, the
The
lens you
left
put.
7.7. But
7.7.
the actual also 7.7. No?
Yes, yeah,
Maybe
because
it's watery.
watering, yeah. Let us see after a few minutes. Let the watering subside.
Okay, so now do over refraction.
You can while waiting, you can do the over refraction. Okay.
Yeah. Also, just now the right side can say is optimum fit already.
I think it is slightly steep to optimum. Let's look at the over refraction and then decide. Maybe one step
Yeah,
or
look.
0.05 millimeter flat would be better. It's just nicer. Right is quite center, quite nice, I think.
Oh, okay. But this patient is zero power.
Mm.
So I use -3, so expected is +3.
Yeah, if you get a
So
+3, then
TLP,
okay lah. So TLP will be 0 lah in that case.
then this will be the lens, final lens, lor.
Yeah, yeah. But ideally, your patient doesn't need lens, but just for the, just
Yeah,
for the,
fitting.
yeah, can, no problem.
But the left side seems no fluorescent already.
It's
Look
gone
straight.
already because too much
Yeah,
watering just now. So it looks like it's a little bit flat. You see, it's decentered, inferior, moving a lot. So perhaps 7.6 would be better for this eye also.
yeah. So actually, I want to fit. But oh,
Because
probably
7.7,
it's a bit
7.7 is a bit loose
flat.
for this,
Yeah,
right?
loose. So need
Yeah.
make it flat.
Yeah.
Eh, eh,
Make it steep.
steep. So lower lah, 7.6 lah.
Yeah. So why don't you put fluorescein? I think just now I saw no watering. She's almost okay now.
Okay, sure. Yeah. But that day I saw a picture for the optimal fit for the RGP. It seems That's
Yeah.
a different fluorescent pattern. No? Later,
Is a
I
diffuse fluorescent pattern everywhere. Like you want the fluorescent to be there
and then
overall.
the overall or a little bit
Yes.
of pulling lah.
Slightly, yeah, slightly. Is consider alignment, not pulling.
The thing eye, I shall look straight.
So this one looks
Okay,
decentered inferiorly. Okay, blink
blinking eyes.
first and put the lens up. I mean, retract the eyelid and put the lens in the center. Yeah, now you see center touch, isn't it? No pulling in the center.
Blink eye. Okay, look straight. So
Mm.
lift the eyelid.
Yeah, put the lens in the center. So you see centrally there is touch, isn't it? Center, there is no fluorescein. When the lens is in the center,
Yeah,
there is
this
no
one
fluorescein. Yeah, so this is definitely flat lah.
touching flat. So make it
Yeah.
curve
So
slightly. So should be 7.6, but no 7.6 length really.
you put a 7.5 lah on this side.
Oh, but this one is after over refraction. Lah.
Yeah, I think you should do over refraction and then you see if we have the time. The right side still okay, but the left side, this one maybe you want to put a 7.5. The right, I'm quite okay. I think it should be fine.
Okay, so now proceed to the over refraction.
Yeah. Over refraction first. Yes.
Okay.
Okay. Yeah.
Ini mana yang lebih selesa? Dua tak selesa. Hmm? Dua tak selesa kan? Okay. Sebelah kanan, right side. I'm pretty sure can see. Can see ah, all lah. This one, last row also can see. Which one is clear? The top row? Top row clear lah. Second and third not clear lah. Okay, left eye. Which one is it clear? Only top row clear. Top row is clear. Second row, third row blur ah. Okay. Take the ah. Let me put this on. Look at the white dot in front. Tengok. Okey, okey. Tengok. Okey. Semua nampak? Tengok. Semua nampak? Belum. Ini? Belum juga. Ini? Bagus, buka. Buka. Masuk dulu sikit lah. Tengok dulu. Masuk ni. Masuk dulu juga. Tengok. Buka. Ada bagus, buka. Sama. Pergi masuk ni memang belum lah. Hmm. Ini? Belum. Masukkan clean kan boleh? Yang ini bagus. Sama. Nampak? Betul. Ini? 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 Sekejap lah. So, bawah je lah. Dapat kan semua? Lima merah, lima hijau, mana je lah? Atau sama? Mana ni? Yang juga. Ni clear tak betul? Clear semua. Ini? Dapat kan? Betul sikit. Ini nampak lah. Dapat. Masuk ni clear kan betul? Buka. Tak, lebih clear. Tengok. Ah, Dua sama. Apa masuk ni? Dua sikit. Mana masukkan jelas sikit. Buka jelas sikit lah. Apa ni? Ni? Yes. Sini. Duduk, duduk. Duduk dulu. Duduk. Sini. Sorry.
Okay, Jerry.
Yes.
Done our reflection? How is it?
Yeah, done.
Okay.
Actually, I quite confused.
Okay.
Regarding just now, left side is flat on the middle. So is a bit flat, so we need to make it steep.
Yes.
And then so we change to 7.5. But the TLP calculator is plus 100.
Let's go through the values together lah.
Okay, sure.
Okay. So Alex has joined our room because Alex
Oh,
is done. So
oh,
so he can also take part in our discussion.
can.
Okay.
Hello.
So your patient is plano, right? Both eyes.
6.6 lah, 6.6 boys.
Original refractive error is plano, isn't it?
Yeah.
And then your trial lens is -3 for both eyes, correct?
Yes.
So your expected over refraction should be
Plus 300.
correct. So what did you get? Plus 300. So what did you get? Obtain over refraction for the right eye?
Both side plus 2.
+2. Both sides you are getting +2. That means you are getting +1 TLP.
Yes, correct.
Okay. Plus TLP usually represents steep fit.
But the degree so the degree will influence the base curve as well.
It should ideally, yes.
Oh, okay. The theory is like that. Okay.
It's not the PLT is -1.
It should be lah, but no. In this case, because expected is +3, right?
But get
He must get +3, but he's getting +2 only.
Mhm,
that means
yes.
it's minus TLP is -1
TLP is plus.
Oh, it's plus
Because where is the remaining +1? That's the TLP. He should get 3 plus, correct?
missing plus 1 now.
So he's missing the +1. So where is the missing +1? That's the TLP.
Yeah. It's
So
not. It's -1 ma.
plus.
Plus. Okay.
Okay. So one more time, because the patient is plus. Patient
It's
required.
plano.
Patient is
Plano, yeah.
plano.
That's it. Plano.
Okay, and then the contact lens is -3.
Content is -3.
So your expectation is to get +3,
Yeah. +3.
but you are getting +2.
Yes.
That means there is a difference of +1. So the +1 is missing, ma. So where is the +1? The +1 is the TLP.
Mhm. So we need to plus 0.20 into the base curve.
So you need to add about 0.5, yeah. But then don't. I think something is not right in your over refraction. Perhaps you must get a more plus lah. Based on the fitting, you should have a more plus.
Just now with the VA with the lens is 6.9 now.
VA with the lens, meaning without any over refraction.
Yeah.
Yeah. There are a couple of factors lah, because your lens is not centered well. The patient is actually looking through not the exact optical center of a lens. So maybe that can also influence. If you see the picture there on his screen, Alex, you can see that
Which one?
the lens is flat.
Oh, this one.
Can see, right? So it's central touch.
Yeah.
And the lens is decentered.
Yeah.
So
Is center touch the TLP should
Yeah.
be minus ma, right?
correct, but he is getting plus. That's the thing. He's not telling.
But for my understanding, to calculate the TLP is -1 lah.
Okay. So -1, when will it be -1? If your over refraction is higher plus. So same example, patient plano, you put a -3 lens, your expectation is to get +3 ma, right?
Yeah.
But let's say he got a +4. That means he
Yeah.
got +1 extra outside in the over refraction, correct?
Yeah.
So why he got an extra +1 over refraction? Because there is a -1 TLens power.
Okay.
Is the opposite. If you get
Okay.
more plus in your over refraction, that means your TLP is minus.
Okay.
If you get less plus in your over refraction, that means your TLP is plus.
Okay.
Less plus ma, because he need 3, so he got 2 only. He got less plus.
Okay.
So the remaining +1 is the TLP. So there is no reverse.
Okay, okay.
Okay, just maybe write down and
Just think
think
first.
a bit more.
Think.
We can
Okay,
discuss
okay.
again. Don't worry.
Okay,
We
okay.
can take another example. So have you refitted, Jerry? Have you refitted the patient again or what?
Because okay, so just now you said because now it's plus 0.20, so it doesn't make sense, no? The TLP is
Yeah,
+1.
somehow the overrefraction is a bit
But the,
weird.
but old fraction, I'm sure it's correct lah, because yeah.
No, sometimes because you have already over minus the patient, maybe the accommodation also influence because you already over minus patient is
Oh,
emetro
oh,
plano.
oh, 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 oh.
So the accommodation and all that would also influence, but not always, but yeah, it could be a factor. But
So
let's just change our lens based on the fitting lah. So right side, this is the left side, isn't it? The picture you are showing is a
yes.
7.7. So
Yes,
just
yes.
change the 7.7 to a 7.5. Let's see what happens.
Already changed. I just changed.
Okay, so let's look at the fitting. So we are actually steepening the base curve. So the fitting should be different. Let's see how it is. Okay, so let's look at the assessment together. Is the patient more comfortable or any difference the patient feel or is the same?
The left eyes, how you feel? Is it more comfortable or same? Same. Yeah, same.
Same, okay. Yeah.
Okay, so now we look at okay,
Yeah. So how is the lens
the
movement and
centration.
everything?
Centration.
Centration, yeah.
You look straight. Centration, nasal and temporal, I think
Yeah. It's
quite
more of the
quite
decenter inferior,
inferior,
decentration
inferior.
inferior. Mhm.
But I leave the eyelid. It seems quite okay also.
Right, okay, yeah. Let's
Okay,
see
so
the
look here.
movement. Yeah. Still moving a bit as usual, I think.
You look here. Oh, it seems within the limbus.
Yeah, just a little bit crossing the limbus, but
Okay.
I think it's quite
This
just
one, this
there
side
lah.
is inside the limbus. Okay, look up.
Yeah.
Look up. This
Mhm.
one a bit out,
So
slightly.
it's
One and
slightly out.
look
Yeah.
down. Look down. It's quite actually quite okay lah, right?
Yeah. Compared to just now, the 7.7, I think this is slightly better. Let's put
Okay,
the
try look straight.
fluorescein.
Ask her to blink. Blink eyes.
So no apical rotation, I think smooth, but let's put the fluorescein and see.
Okay.
Let's see what happens to the fluorescein
Oh.
pattern. Does it become better or no?
是要 check 不懂。去哪？我 okay, chin here. Okay, look up. Okay, blink your eyes.
Okay, let's see. Yeah, see the fluorescein pattern is better
blink your
than
eyes.
just now. Put your red filter, put your yellow filter just now. Yeah. See, totally different, isn't it? Now you have a centrally
eyes.
also you have fluorescein.
Just one the fluorescein, is it too much or just quite okay?
I would actually accept it lah. I think it's not too bad because
Yeah,
just
blink your
leave
eyes.
the lid.
Okay, open eye.
I think I will accept it lah. I would accept it because you can clearly nicely see the pupil
Blink
there.
eyes.
And
Oh yeah.
it is a good tear exchange. So definitely the fluorescein pattern is different from 7.7 to 7.5. So somehow the over refraction is not telling lah. So
Okay, put this down. Okay, so now is 7.5,
better.
7.5 better, yeah. So just now, if we follow the TLP, so we should add right,
Yes.
7.7 to 7.9.
Yeah, but I don't know. I think the over refraction might be
Okay, not correct.
yeah, maybe. Is it possible for you to put both 7.7 and 7.5 together on the screen? Two picture together? Possible? Just for
Never
our
put.
comparison.
I never put before. I think cannot. Wait, I think can.
Uh, should be
7
possible.
can
Just now.
can. When this one and this one.
Hey,
Eh?
you only put one just now. The other one you didn't select, I think. Okay, yeah. This one and yeah, this one.
Yeah.
So you see there is a difference, right? The top one is actually 7.5 base curve, which has a good center, slightly steep, perhaps maybe 0.05 flat would be better. Okay. And then the edge and all that looks quite okay. But if you go to the bottom picture, bottom is 7.7 is a flat lens already.
So theoretical wise, here should be a bit fluorescent. Then the side here, the alignment here should be black lah.
Should be fluorescent as well. Should be
Should be
fluorescent. And
the whole thing fluorescent.
yes,
Then it will affect the edge law.
It doesn't have to be that much, but there must be a fade
slight.
fluorescent. Yeah,
But here will
diffuse.
be the edge will be thicker lah.
Slightly should be thicker, but yeah, I think the top picture should be slightly maybe. This is 7.5, right? 7.55 should be okay already.
Okay, one question. Regarding the edge clearance, what does that mean?
So edge clearance means is an indirect measure of the width, the thickness of the edge. So
And then the edge width, what's the difference between edge width and edge clearance?
Edge width, you measure how much is the measurement.
Oh, this one. So this one is about 1 mm on the superior.
Yes. So I will say average. Edge clearance is
One, no?
average, and edge width is 0.1. So if let's say edge width is less than 0.5, it means low.
Sorry. Edge width should be 1.0.
0.1 mm.
Or 0.1 cm lah. 0.1 m. 0.1.
Not 1 cm. 0.1 mm.
Okay, 0.1 mm. 0.1. So this one, the top one is overall is 0.1, right? But the temporal
is slightly thinner. Yeah. But again, the lens is not well centered. So I think once the lens was centered just now during your assessment, it looked quite symmetric when you were looking at this thing.
Oh, okay. So just now, this one, the edge clearance is what? Low, average, or high?
I would mark as average.
Sorry to ask again. The edge clearance is meaning what?
The edge clearance is the width of the edge. So if the edge width is acceptable, if the width, the measurement of the edge.
If it's 0.1, then it's average lah.
Yes.
Oh, okay.
If it is thin, then you will put low.
If it's less, if it's 0.05. For example, this
less than 0.5.
Example, this temporal side is like 0.05 lah.
0.5, yeah, very thin edge.
0.05.
0.05, less than 0.5, yeah.
Yeah.
So then you will say it is a bit thinner. So low edge clearance.
So 0.1 is considered
0.1 to 0.1 is okay, is acceptable. Yeah.
Okay, understand now.
Okay. So at least here you can clearly see the difference. But I think, yeah, let's do over refraction for the left side. You haven't done again the over refraction with the 7.5 lens, right?
Okay,
yeah, maybe you want to do a 7.5 over refraction,
sure.
then perhaps you may have a better answer, I think.
Yeah, sure. Yeah, I do the over refraction now.
Can. Yeah.
Sorry, Mr. Fee.
Yeah.
In this case, is it the lens a bit small?
You could increase the diameter, yes. Yeah, but standard normally is 9.2 to 9.3.
Okay.
So sometimes you do not want to play too much with the diameter because when you order, unless you have a trial and set, you
Means that if we have the tri-lens set, then we can try
better.
the size lah.
Yes, yes,
Because
yes.
once I will alter the size, maybe the base curve will change lah. The fitting will
Correct.
change lah.
The fitting will change. Yeah.
Yeah.
So I do not kind of do the diameter unless you really have to do it. In some eyes, you think the first
Too
thing
large.
you is
Too
too
large.
large or too small. But I would prefer to do a fitting first before I make that decision.
Or is it have a diameter that usually people fit?
9.2, 9.3 is a traditional one. Every trial lens would usually have this diameter.
Okay.
Some of them will give you 8.8 and 9.6 as well. You can
Okay.
go up till 9.6, 9.8 millimeters as well.
Mm.
But most of the eyes will fit with 9.2, 9.3 lah.
I see. Okay.
Okay, so let's just wait for Jerry to finish his over refraction, then we will see. You can probably wait here, or you want to join Kevin also can. I can
Okay.
move you there lah.
Okay.
So then we can have a look, and then once Jerry is done over refraction, then we'll meet in the main room. Okay. Is all okay, Jerry? Done over refraction?
Yeah, I went to the washroom. Done, yeah,
No
done.
problem. Yeah.
Done
Okay.
already.
So
The TLP on the left plus 225 lor.
okay. So at least it still doesn't tell you something is. Let's see. We will discuss it together lah. So I have you removed the lens already?
Yeah, I'll remove it.
Okay, so I will close the room. I think let's discuss with Alex and Kelvin together lah.
Okay.
Huh?
Can.
Okay, so just keep your screen share on. I need them to see the pitting. I think this is a good thing to show all of them. If you can just leave
Can.
it on,
Yes.
and we will, see that. Maybe you need to
Okay.
share again later.
Okay.
So, okay. Can you hear me? Okay.
Yeah.
Okay. Yeah. So Jerry is done. Yeah. So let him join, and we will have a quick chat about that. Okay. He is on the way.
Yes, hello.
Okay. Hello. All right. Okay. So good. So let's quickly have a quick discussion. I think we have discussed most of it in the individual session, but let's quickly have a look. Can you reshare your screen, Jerry? I think it stopped sharing, and I'm not sure if
Share.
you are aware that the video is off. Your video is not on. I don't know whether you know or not, just to tell you lah.
You mean my video is not
Yeah.
recording?
Yes.
Eh? You are.
You can see us, but we cannot see
I
you. only.
can stop, right? Can I stop or just continue?
Continue. Yeah.
But
No,
already
I mean the
continue, of
video, the
course.
screen record is okay. Recording is okay. We can't see you.
Sorry.
So I don't know whether you. Okay. Because sometimes you think that everybody can see you, but actually no. Okay,
Yes.
so just quickly have a discussion about this Jerry's case there. So this is the patient's fitting, right? Just remind me if I'm wrong. So the bottom picture is the 7.7 base curve. And then you can clearly see that there is a central touch. Mid-peripheral pooling edge clearance is also high because the mid-periphery and the edge is actually mixed up, right? So this one, the bottom one is actually a flat fitted lens. It's actually flat, right? So it's the same eye. This is flat. I don't know whether you can see or not, but I'm
Can.
writing something. So this is flat. Okay. So the same patient, we actually fitted a 7.5 base curve. So this is 7.5 base curve lens, correct? And this is 7.7. So this was our first trial, was flat. And then because it was flat, we fit a steep lens, 7.5. So this one looks optimum to steep because you can clearly see the centrally the fluorescein is there. And then mid-periphery looks that there is no fluorescein, but actually when the lens was quite in the center, we could see that there was a good fluorescein exchange. So no issue. The edge also looks quite okay, except this side is a bit thinner. Okay, could be because of the light as well, but I usually would accept this. So this one maybe is optimum to steep lah. So that's what I wanted to actually show within the same eye, the difference in the fitting pattern. So 7.7 was flat. You made it steeper to 7.5. It shows optimum to steep. Okay. Now, just looking at the over refraction calculation, so there was a little bit of a issue, I think, in the right side specifically. So patient is plano. Okay, patient is plano. RX patient is plano.
Now we look
Contact,
at the left, right? Left.
yeah, overall,
Which-
this is left.
All right. Yeah.
Patient is plano, right? Left eye also?
Yeah, both side plano, yeah.
Both side plano. So contact lens is -3,
Yes,
correct?
yes.
So your
Yes.
expected over refraction should be?
+3.
Expected should be +3. Okay. Considering that the TLP is 0 lah. This is the normal situation. But what was your over refraction with this one? With the 7.7? Huh?
Right eye, is it? Or both +1. TLP +1.
Left eye
Oh,
with
left
the
eye, +1.
7.7. +1.
+1. Yes.
So +1 is your +1 is your over refraction, which is obtained over refraction. Obtained over refraction is +1. That means there is a residual +2, which is missing. So this +2 missing is your TLP. Understand? But the problem is plus TLP.
Oh, sorry. The over refraction is +2, sorry.
Okay, +2. Okay. But
Oh,
still,
+1.
is the story still remain the same lah?
TLP is +1 lah. Okay.
TLP is +1 because this is +2.
Okay, yeah.
So
Yeah.
TLP is,
Yeah, yeah.
even though it's +1, that means plus TLP is steep, right? But the fitting is showing flat. So a couple of reasons, like as I was just mentioning in the other room, the first reason could be the patient original power. You must double check. Maybe the patient's original refraction is perhaps changed. We don't know. Okay. Or the accommodation, because patient is plano and you have put a -3. You have over minus the patient. So patient has started to accommodate, and that is why he's accepting less plus. Okay. So in that cases, you may want to do a defogging refraction. So you put a +5, +6, and slowly reduce the plus until you get your MPMVA, maximum plus, maximum VA. Okay. Shouldn't happen, but sometimes, yes, it does happen as well. But this is what we need to do. The third reason could be, which is again very rare, is your trial lens power is not -3. You think it is -3, but the trial lens power is wrong. Sometime it can happen if you have real patient, they might have swap lens. If you have a real patient come for aftercare, suddenly you see, hey, fitting and TLP doesn't tell you. Fitting is good, but I get a TLP. Maybe the patient has swapped the lens. You might have to check that. Okay, so that's a bit of discrepancy here, but I think we need a little bit more practice, and then you should be okay. So let's look at the 7.5. What was your obtained over refraction with this?
+2 over refraction +75.
Plus 0.75
Yeah, refraction. Over refraction.
for the 7.5 lens.
Yes,
So
yes.
again, it's showing the same thing. So you are getting a plus, how much? Plus 225.
225 TLP.
Which is again a bit of a, not to say that this is so steep that you will get a plus 225 TLP. This looks quite okay. Maybe about plus 050, plus 075, I can still accept. So it's a little bit too much. So same thing, I would just encourage you to probably take a little bit more time in your over refraction and finalize on that. So try to push the maximum plus. Okay. So if let's say you got the TLP about plus 075, plus 050, yeah, I accept it lah, because the lens, the center is a slight pulling. That's why I say it's optimum to steep. It's not 100% optimum. It's optimum towards the steeper side a little bit. So if you got a little bit of plus over refraction TLP, I will accept. But plus 225 is a slightly higher lah. Okay. So yeah, just be extra careful when you're doing over refraction. I think more practice on over refraction would be better. But when you fit real patient, of course, you're gonna do your proper initial refraction and then you follow the process, it will be smoother. Don't worry. Okay. Any question in this calculations? All I hope you can, recall back lah everything.
Yeah, calculation is okay.
So just I think there is a couple of example in my pre-recorded session as well. So just recap back lah. You should be okay.
Okay,
Just
okay.
two important things lah. If you get over plus in over refraction, okay, that means your TLP is minus. That means it's steep. And reverse, if you get less minus in your over refraction than your expected one, that means the TLP is minus, that is flat. So just two things lah is how you remember. It makes your life easy lah. Okay. So that's about Jerry's case. The right side again was a similar story, 7.6. You fitted the right side, but the fitting was just okay. Again, the TLP was not really telling lah. So we will practice more lah. Okay.
Oh, so if the TLP was 50 or 75, meaning that one we can prescribe lah.
Yeah, TLP, ideally we want 0. Okay, but in some cases, about 0.50 difference is still acceptable, especially in the high minus side. Low minus, not much. Low minus, you should ideally get 0. But if in high minus side, in a slightly corneal toricity or toric lens, a plus minus 0.50 range is still acceptable. Not for low. You do not want to over minus the patient. This patient will come back at the end of the day and say, I got headache. I got eye strain. The moment I wear your lens, the end of the day, because you have over minus, just the accommodation has gone for a crazy stimulation. At the end of the day, they will say, I got headache and I got eye pain. Then is a problem. So don't over minus. Okay. All right. And then, yeah, the room 1, Alex, I think you fitted both eye with toric, soft toric. Right eye was just nice. Push-up test was everything acceptable. Rotation, we saw what, 20 degrees
20.
clockwise.
Yes.
Okay. And then the VA and all was still okay after over refraction. So that was good. Left eye was better. No rotation, and then over refraction was having cylinder because patient original requirement was 125, but because of the availability, I think you fit a 075.
Yes.
So my advice would be, I think I did tell a lot of others probably that when you're fitting patients with astigmatism, try to fit. It is better to fit the exact astigmatism or cylinder power and the cylinder axis when it comes to diagnostic lens. So if the patient need 125 cylinder at 180, please put 125, 180. The sphere can be different. The spherical power you can do over refraction, but toric over refraction is a bit challenging. You can do over refraction, but to finalize the power, it will be challenging. So that would be the comments and the suggestion. And then moving to the room 3, Kelvin also, yeah, we fitted both eyes RGP, both eyes flat. The right eye TLP didn't match, but the left eye TLP did match. So yeah, the calculations and the over fractions part lah. Okay, any questions for today? I think we are good. We had
Mr. FB, if the rotation is 20 degree clockwise, so our contact lens axis we have to alter, right? Have to change the axis.
Yes, so changing the axis will also depend on the visual outcome. So what I will say is, let's say there is a rotation, but if the vision is good, do not change first.
Okay.
because that might be the axis where it settles down. Okay, but this should not be beyond 15 to 20 degree lah. You cannot have the axis there at 35. Okay, so if with 35 your still vision is good, I think the first step is change and see the visual outcome as well.
Okay.
So sometimes a lot of practitioners make that mistake. Whenever they see rotation, they straight away change the lens. So they don't really look at the visual outcome. They see 10 degrees rotation, I apply my cast rule, I apply last rule, 10 degrees clockwise add. So I straight away order 180 because the trial lens was 170. And then the lens come in, patient said the trial lens was better. So always remember to take both VA, the visual outcome, and rotation into consideration together.
Okay.
So in your patient, actually, I will not, because your vision was optimum after your over-refraction, which was just spear over-refraction.
Yeah.
And patient can see 6.6. So I will not change.
Okay. So means if it's clockwise, we have to minus or
add. Cast is
add,
clockwise add, anti-clockwise subtract.
Okay.
That's rule.
So if 180 is the patient's, the trial lens is 180, so I have to plus 20 means that 20 lah.
20, yes, correct.
Yes, 20.
Yes.
Okay.
Okay.
So
that is.
I have one question.
Yes. Go ahead.
Okay, let's say for my right eye from 8.0 to like 7.8, but the initial centration is still nasal inferior. So, but the pupil size is fully covered, even though when the eye is like dilated. So, is it possible to still fitting that, or we have to reject the lenses as well?
So good question, because just now we saw, I think in Jerry's case also, the lens was decentered, but because of the lid pushing the lens down, isn't it? So you must look at the reason of decentration. If the lens is decentered because of the lid interaction, because the lid is pressing the lens to decenter, and does it affect the visual outcome in dim light versus normal light? So if the lens is decentered a little bit, acceptable. What I mean by acceptable decentration, it shouldn't be definitely outside the limbus lah. Staying within the limbus, staying within the iris and the corneal region, but it is slightly decentered. And even though the vision is not affected, then maybe you can just go ahead and prescribe.
Should we assuming that after the patient wearing for a month, then there will be like slightly what we call that staining on the inferior part?
Not really. Not because of the decentration. Because every time the patient will blink, the lens will move. So that's why when you always check RGP, you must have a good post-blink movement. So your post-blink movement ensure that there is a good tear exchange.
Okay. So if the scenario is like upside down, patient count for after K, then I realize a lot of staining on the inferior part. Then is it the fitting of the lenses where I have to change it as well, or I just make the diameter larger?
So you must actually find out why there is inferior decentration. It could be because of one of the main reason is partial blinker.
Partial blinker. Okay.
So patient is blinking but not fully. So lens fitting might be better, lens fitting might be good, but because the blinking is not complete. So you just treat the patient blinking. You explain them forced blinking exercises, see them in 2 weeks time, maybe it's okay already.
I see.
So you always want to find the problem first. Where is the problem? Not always the lens is the issue.
Oh, I see.
If let's say the patient was not a partial blinker and you still have inferior staining, so sometimes you also need to look at what is the type of staining. Is it ... type, diffuse? If diffuse, is the patient cleaning the lens properly? The cleaning method, the solution and all this. if the patient has an inferior staining, which is like a scratch like that, it's like a even margin. Is it the lens edge pressing? So treat the problem.
All right.
But yes, one of the reason in terms of modifying could be changing the diameter as well. Yeah. No problem. You can change diameter. I think Alex was just now asking changing diameter, how to, this thing. It will be better to do the triagnostic fitting with the new diameter lah. Because base curve, you can slightly assume, okay, from 7.9, I go to 7.4. I assume that it's going to be steep. It does happen with the diameter as well, but it is not so much of a clear-cut image with diameter. Diameter has a bigger influence as well, because the landing zone will be different. The larger you go, the farther from the cornea the contact lens land. And we know by anatomy, the cornea is very, very flat at the periphery. And then the lid interaction will be influenced because the more larger diameter, it may have more lid interaction. So diameter relation changes is not very straightforward. Still, I even though you have fitted thousands of cases, I do hear from experienced practitioner that if they want to change the diameter, they would like to see the fitting. But base curve, yes, without changing, it's straightforward. Diameter is a bit challenging, but can be done.
Okay, understand.
Okay. Any other questions? Anything which comes to your mind or
So,
anything?
Mr. FV, if I plan to start my RGP lens fitting, what are the supplier that out there that you recommend?
All RGP lens supplier or distributor are actually having good designs, to be honest. My recommendation would be that whichever supplier you choose, you must know the design. Now, when I mean by knowing the design is you must know what parameters they can modify for you. So some of them will tell you, okay, I only have these two diameter. I only can make you in 9.2 and 9.6. You tell me 9.8, I cannot. You tell me 8.8, I cannot because they cannot manufacture. Okay. Some of the manufacturers will have an option that you can increase the edge and decrease the edge. Some don't have. So it all depends on whichever you choose, you must know what modification or what flexibility you have to modify the lens.
Yeah, in terms of the comfort,
comfort
and quality. Comfort and quality. It means that the most patient that can accept the lens, rather than just put up and have to take very long adaptations.
Correct. So I will give you, it's not a diplomatic answer. I don't want to give you a brand name, but what I'm trying to say, what I'm saying is, when you talk about comfort, that's something which you need to kind of think about it. More comfortable lenses would be the softer material. Okay. But when it comes to softer material, they can only neutralize lower astigmatism.
I see. Yeah,
so
makes sense.
So if let's say example, a Manicon RGP lens material is soft. So one diopter cylinder, no issue. But the moment you go 150, 175, you will have to fit toric. But on the other hand, you have another brand which has a slightly stiffer material. Oculus, for example, Boston material. They can mask astigmatism up till 150, 175 with spherical design because the material is stiff. So even though 175 cylinder, you can fit spherical. You don't need to go until toric. So both sides are there. For your practices, I mean, if I were to invest or I were to start RGP practice, I would always like to deal with two different suppliers. Instead of having one. So you have two different suppliers, you have two different materials, so you have two sets, and then you can play around much nicely.
Yeah.
And for
So
business, you also need to look at the turnover rate, meaning how fast they can give you the lenses. What is the warranty period they can give you? So all this you must also look at. So most of them give you like a 2 months exchange warranty or something like that,
yeah,
which is
yeah.
okay, which is standard.
Unlimited exchange, 2 months.
Sorry? No, one exchange.
No limited.
One-time exchange, you see.
One time. No, one time only. But some of them will give you two options. You can buy with warranty, without warranty. I think Manicon has that option. You buy with warranty is slightly expensive. You buy without, you buy without warranty is slightly cheaper. Yeah, correct.
Okay.
Actually, correct. So you save a little bit there, lah. That's a profit for you, lah, basically.
So come to like because just now already say for the stick and the soft material, right? So if actually 2 days ago I faced a patient, he really like to wear glasses, and his astig is like -4.5 and -5.
Okay.
With like myopic like -1 to -2 lah. Then if RGP is it the best so far the best way for
Yes.
patients?
Yes. RGP for high cylinder would be definitely best, but I think he will most likely need a toric RGP, especially back surface. Based on the refractive error you have told me, -1 with a -4 cylinder, definitely I think is a corneal astig. But yeah, do a kerato, get the astigmatism of the cornea. Most likely he will need a toric RGP. And of course, the outcome with toric RGP will be good. Sure.
So means we need the what topo lah, is it?
If you have the topo, is the best, but not everybody may have the topo. You can fit on keratometry also. RGP keratometry is good enough.
Okay.
You don't need a topo compulsorily. But yeah, it will be good to have a topo so that you have the entire, shape, and then based on that you can also modify. But kerato is good enough.
Never mind. I already referred to Kevin because he going back to KL already.
Yeah, he can wear a toric RGP lah. I think toric RGP would do good wonders unless he has a special request. I mean special special activity to do with the lens. So for example, if let's say the patient want to wear contact lenses for combat sports, taekwondo, all this. So in that case, you will have to give him a customized soft toric lah. Don't fit RGP in boxing.
But he just learn medical stuff, then
Medical staff, full-time wear, I think RGP will be much nicer. He will enjoy the clarity of vision with the RGP.
Then correct lah. I refer to Kevin already.
Yeah. So yeah, let him fit. But he's from KL or he's from
Yeah, actually he's from KL.
He just came to your place.
Today he will fly back. Then might be visit Kevin on Monday.
Yeah, can then they can do the follow-up, and probably when you are in KL, you can request if you can go and do the aftercare together lah for your next sem.
He will coming back after 1 week plus or 2 weeks like that.
Then you can do the aftercare here lah. You can share patient also.
Yeah, sure.
Okay. Anything else?
Oh,
no. Okay, good. So I think
Thank you.
we are good today. I think Jerry can stop sharing, and I think you can also stop your computer so it can,